Okay.
Okay,
Yes,
please
sir.
go ahead.
So, good evening, everyone. Welcome to the IMIC program, which will be recorded and hosted on the Facebook page of International Medical Information Center and Shastho TV. This webinar is specially brought to you by IMIC and Icon Cancer Center, Singapore, along with BANCAT, the Cancer Trust, and Shastho TV. This is a weekly session as a direct office of different international hospitals. The motive of IMIC is to arrange such webinar to discuss on different health concerns from international experts along with experts from Bangladesh to fight this corona pandemic and to create awareness among the society to be concerned about our health and our lifestyle. So as you already know, our topic of discussion today is COVID-19, gastrointestinal, colorectal, and pancreatic cancers. As we all know that cancer is predicted to be an increasingly important cause of mortality in Bangladesh in the next few decades. According to the Bangladesh Bureau of Statistics, cancer is the 6th leading cause of death, whereas colorectal cancer is the 2nd leading cause of cancer death, which is something really very sad because this cancer is very much preventable with early diagnosis and proper treatment management. So before introducing with you with our experts, I'd like to inform you a little bit about the Icon Cancer Center, which is the part of Icon Group, Australia's largest dedicated provider of cancer care. They have a strong and prominent multidisciplinary team who have received specialist training, work in world-renowned cancer centers. They are dedicated to delivering personalized, evidence-based treatment plans to support patients and their families through their cancer treatment after combining Singaporean and Australian treatment approach. So let us introduce with you the panel of experts. We are extremely honored with the presence of Dr. Robert Lim. Thank you so much, sir, for joining with us. It's extremely honor for us. He's an institution for the cancer treatment. If I would like to inform about Dr. Lim, is not possible to explain his achievements or something with this session. Still, just to inform you, he is a medical oncologist and has over 20 years of experience, more than 20 years of experience in treating cancers, especially expertise in gastrointestinal, liver, biliary, and pancreatic cancers. He is a graduate of both the University of St. Andrews and University of Edinburgh. He had postgraduate training in internal medicine followed by hematology and medical oncology at the New York Hospital. Dr. Lim is previously served as the head of the Department of Hematology Oncology and Associate Director of the National University Cancer Institution, Singapore. During that time, he did research focusing on developing new drug treatment and improving our understanding of the unique problem of Asian with cancers. Thank you so much for joining us, sir.
Thank you for the invitation.
Thank you, sir. So, and we have Professor Dr. M.D. Mofazzel Hossain, sir. He's a very prominent doctor from Bangladesh, and we are very much proud to have a doctor like him because after his treatment, Bangladesh patients get some hope for the cancer treatment. So he is the Chief Consultant Medical Oncologist at BRB Hospitals Limited. He is MBBS, FCPS Medicine, FSCP from USA, FRCP Edinburgh, and FRCP Glasgow. He had his observership. I mean, I would like to mention this thing. He had lots of training and lots of things he already achieved. But I would like to mention that he had his observership training from Singapore National University Hospital in 2006 under Dr. Robert Lim, when he was the Chief of Medical Oncology and Hematology of NUH. Thank you, sir. Thank you for joining us and giving your time during this pandemic. You are busy with our lots of patients, but still, it's really pleasure for IMIC.
Thank you for inviting me to attend this meeting. It's my honor and pleasure to be with all of you, and in particular with a personality like Robert Lim.
Thank you, sir. Thank you.
Likewise.
Thank you. And we have Mr. Nazmus Ahmed Albab, sir. He is the founder and trustee of Bangladesh Cancer Aid Trust, BANCAT. He's a true inspiration fighter for the cancer survivors, because he is also a cancer survivor, social influencer for us. Thank you, Abu Bhai, for joining us, making your time.
Thank you. Assalamu alaikum. Thank you.
Thank you. So, Dr. Lim, I'd like to start with you. I know lots of patients are waiting to hear from you. So, sir, since you are working especially for the patients, Asian patients with cancer, I'd like to hear from you, how common is the colon cancer and gastrointestinal cancer, especially for the South Asian patient? And what age group of patient suffers most for this cancer in our subcontinent?
Thank you. So,
and what are the risk factors related to this?
So may I just share a screen for a moment here? I got some data here.
Yes.
Gosh, I hope I can. Sorry, I'm not sure if I'm doing this right now. This, no, this is the one. Oops, sorry. Let me see. I'm not sure if I'm doing this right. Okay, yes, here we are. So I was searching for some data on the incidence of cancer issues in Bangladesh, and this comes from the Global CAN, which is an international group which is headquartered in Switzerland. And actually, you see here that colorectal cancer is not in the top 5. It's actually in the top 10 of cancers in Bangladesh. You know, esophagus, lip, oral cavity, breast, lung, and cervix are the top 10 in general. If you go down here, you see that basically for males, it is esophagus, lung, the lip, hypopharynx, and stomach, and then other cancers. And in females, as might be expected, breast is common as well. But colorectal cancer, let me go down the list, this document here I'll show you. Colorectal cancer, although you see here, is actually listed as number 1516, but actually it should be really combined. Colorectal should be combined together. So it actually comes to, I estimated, around the 10th most common. And here you have indeed, if I go down to the bottom here, you see colorectal is just making it to the 10th. So it's a common cancer. And as you can see here on the right side of the screen in red, the mortality from this cancer, you can see it's almost equal to the incidence as well here in the blue bar. So it is a major issue here for the population of Bangladesh. So risk factors for colorectal cancer, unfortunately, as we all age, colorectal cancers, cancers is one of those diagnoses which tend to be somewhat more common, like cardiovascular disease, but cancer is obviously there. People talk about diet. So diet, diets low in fiber, high in fat are associated with a high incidence of colorectal cancer. And then sometimes there are family histories or risks in terms of lots of polyps or, as well, or previous colorectal cancers and families as well, which will confer a risk onto the patient too. So these are some of the general issues or facts that go with colorectal cancer in general. It is a common cancer as countries get more developed, and certainly Bangladesh, with its encouraging, progress over the years, is heading that way too. So you will probably see more of a shift, to colorectal cancer, like we have in Singapore seen over the years as well. So these are some of the basic issues that go with the risk. Now, I touched upon family histories, and that's an important issue to keep in mind for people who have, no family members who have had colon cancer. Now, this is also especially pertinent if the patients themselves have been younger, especially age 50 or younger. Then there's probably a heightened risk. And now there's also another subgroup of patients with sometimes other types of cancers, which may be a part of a whole constellation or group of a certain genetic risk factor called Lynch syndrome as well. And later on we can touch upon that. Yeah.
Thank you so much, sir. Because yes, this information should be very informative, because patients always seek to know why they are suffering from colon cancer, why this is so common in Bangladesh. Yes, there are some factors related with this disease, increased number of diseases like colon cancer. So I'd like to hear from Dr. Mofazzel, sir. Sir, since you are working in this sector for almost more than 25 years, I'd like to hear from you, sir. What's the difference between the cancerous polyps and the regular polyps? Because, is that all polyps eventually becomes cancerous?
Thank you. Dr. Lim has already mentioned about the propensity of the polyps to become cancerous. Actually, the polyps, all polyps are not cancerous. There are certain polyps, the polyps do not become cancerous overnight. They gradually turn into malignancy. And usually there are familial polyps. We call it familial adenomatous polyposis, such as Lynch syndrome, as he already mentioned, though they do not constitute more than 5% of the total colon cancer. These are there is a gene called adenomatous polyposis coli, or APC gene, or there are other symptoms, MAP, multi-associated polyposis. These polyps, actually adenomatous polyps with proliferation, atypical hyperplasia, and these, along with these hereditary syndromes, these polyps are actually malignant in nature. Pre-malignant conditions, polyps by themselves are not cancerous, but eventually they turn into malignancies. In a family where there is a colon cancer, and along with that, during the colonoscopy, you find that there are polyps in other areas of the colon, large gut, then the younger members of the same family should undergo colonoscopy, and you may find a lot of polyps, and polyps should be removed and biopsied. If there is a polyp which is pre-malignant, then he should frequently be checked for the recurrence, because they have an inherent tendency to recur, right? So every polyp is not a malignant polyp, but there are certain characteristics. Those are the polyps which are pre-malignant, and they can, over a long time, they may eventually turn into malignancy.
Thank you, sir. Yes, because whenever we patient diagnosis with a polyp, they start thinking if this they're turning to as cancer. So while talking about these things, so it is came to in my attention, and lots of our patients come with the complaint that their body gets more polyp, and their polyp is, the body is formed to this, getting these polyps. So is there anything with the genetic link? Already you mentioned that, and actually any environmental impact of this, if you kindly inform us. I'd like to start with Dr. Robert Lee. and Dr. Mofazzel then.
Sure. So I think first of all, finding a polyp, a certain number of polyps, is not uncommon, and that should unto itself not be too alarming. In fact, by removing the polyps, you actually do decrease the incidence, the chance of developing colorectal cancer, because it is actually not necessarily a cancer at that point. If you were to leave it in there, it could develop into a cancer. So that's actually a good thing. Now, the issue may also be, what if someone has multiple polyps? So, many polyps, more than 20, more than 50, or even hundreds of things like that. So this is where what Professor Mofazzel, alluded to, the FAP, familial adenomatosis polyposis syndrome is the issue. And now that's not a particularly common scenario, but occasionally we do see patients with multiple polyps. So these patients need extra attention. They may need more frequent colonoscopies, and in fact, if there are too many polyps in the end, sometimes the concern is high enough that maybe we may even recommend prophylactic colectomy surgery to remove the entire, and also remove that risk of developing colorectal cancer in the intestine itself. Okay.
Yes.
So, but diet, obviously, like I mentioned, high fiber, low fat, these sort of diet, they are the principal ways that also associated with decreasing the chance of polyps forming. But again, don't be particularly alarmed if a patient or someone were to develop 1 or 2 polyps, and when they had a colonoscopy, a screening colonoscopy, that is not particularly alarming. That can be removed, and that's good. And all they need is a follow-up colonoscopy, and then obviously look at their diet and make sure that they are adhering to these sort of general recommendations. Yeah.
Yes, exactly, sir. Exactly, because I'll try to hear from you more about the diet and the lifestyle of the patient. But by this time, I have a concern from Dr. Mofazzel Hossain, sir. Actually, what are the symptoms of colon and GI cancers? If you kindly inform us the stages of cancer, like colon cancer or GI cancer.
You are asking about the symptoms?
Yes, symptoms and the
Right.
stages, different stages.
Right. The colon cancer symptoms, there are certain symptoms which are very common, such as altered bowel habit, then parectal bleeding, then if the tumor is located in the left side, then there may be features of obstruction, particularly in the rectal region, and the patient is younger one who may overlook this. A time this is particularly in our country, that young patients with cone and sigmoid malignancy, they come with obstruction. Though there are history of parectal bleeding, they ignore it. So when these things continue, there may be other features like intestinal obstruction, then anemia. Because of repeated bleeding, there may be features of anemia. And when there is further dissemination of the disease to the abdominal organs, there may be abdominal distension, such as caused by either obstruction or ascites. When it is very advanced, when there are features of ascites, there is very advanced disease. Then there is a tendency of this malignancies to spread to the other organs, particularly liver, and then there will be loss of appetite. The first thing I said, altered bowel habit, then your parectal bleeding, then altered bowel habit and alternating constipation and diarrhea, parectal bleeding, then anemia and weight loss. All this can come with the advancement of the disease. These are the symptoms.
you had with get consult the polyps or colon cancer?
No, for polyps, usually they do. These are actually detected during routine screening examinations. But if the polyps are more in number, then there may be signs of absorption, malabsorption, or there may be some pain, vague pain, or some altered bowel habit also, right? Polyp, a single or few polyps may not cause any kind of symptom at all. Those may be detected during the routine examination.
I see, sir. So, sir, as per your experience for decades of time, so for Bangladeshi patient, in what stages usually a patient visits you, and what are the advanced treatment approaches we have here in Bangladesh? I'd like to hear from Mofazzel, sir. Then I'll
Most of patients who think very few patients present in stage and a considerable number of 20% presents 4. Stage 4 means widespread intra-abdominal dissemination, including liver, then lungs and bones. All organs are involved. It is stage 4. And when there is involvement of the perirectal lymph nodes, that means the lymph nodes beyond the colon, they are stage 3, right? Most of our patients do present in stage 3. Few patients usually present in stage 2A or 2B. And stage 1, it's very rare patients, very rarely patients present in stage 1. Actually, stage 1 patients are curable by surgery alone. They don't need any adjuvant treatment, neither chemo nor radiotherapy in colorectal cancer, no chemotherapy in colon cancer in stage 1 or 2A. If there is stage 2B, then stage 3, then we administer adjuvant chemotherapy. There are certain drugs that depends upon actually the risk as well as the choice of the consultant. And if it is stage 4, usually it is palliative treatment in the form of chemotherapy along with the immunotherapy. Actually, with the diagnosis, we do not only diagnose by biopsy or histopathology, we do certain molecular testing also. If those molecular testings are the reports are available, then we can decide whether the patient is also going to be benefited by certain immunotherapy. Nowadays, the era of immunotherapy, other than this recent introduction of immunotherapy, we used to, in this advanced stage disease, we use certain other antibodies such as bevacizumab, cetuximab, and panitumumab. But for them, we need to have some molecular testing. BRAF, KRAS, these are tested, we do it, EGFR. But many of our patients cannot afford these costly drugs. So we usually treat them with the conventional medicines like oxaliplatin, capecitabine, 5-fluorouracil, irinotecan, leucovorin. These are the common used drugs. Not many acceptable for treatment of colon cancer, but in the recent past, many immunotherapy drugs as well as the antibodies are coming up, so they can be of beneficial use to the patients if they can afford. We are using it, but not very frequently.
Exactly, sir. For your information, this should be very informative to our patients that yes, there is a hope from Bangladesh and we have advanced treatment management here also. So, Albab Bhai, since you can relate that the data is coming that the patients here only visits our doctor, the disease already in the advanced position. So, as a founder of a cancer association, I'd like to hear from you about the urgency of creating awareness among the society, and especially for the improvement of our lifestyle, our food intake. If you can discuss on this matter.
Thank you very much. Thank you, Dr. Mofazzel, and thank you, Dr. Lim, And it's a pleasure indeed to be here speaking in this platform. And thank you, Farzana, for giving me this opportunity. Firstly, let me go back to the data part. Just briefly, that we are at the moment talking about the cancer related to the digestive system. And in comparison with the other cancers, whether you talk about lung, whether you talk about breast, or you talk about cervical cancer, these are the cancers which are more prevalent, as a matter of fact, because there are a lot of awareness programs out there. These are more apparent, more visible. But the cancers related to the digestive system, which is colorectal, stomach, liver, intestinal, these seem to be kind of not always talked about until and unless they surface. And by the time they surface, they are at a very advanced stage. Now, that is one scenario. And the second scenario is, which I always say, that there are three kind of behavioral aspects that we as human beings, or we as the people of Bangladesh, we tend to have. And if you segregate the demography of people affected with cancer, of course, everybody with the present condition, everybody's under threat. Let's not deny this fact. Let's not remain in denial. But if you talk about the 10% who are affluent, and rest of the 90% are actually, who are underprivileged, not educated. Now, if you talk about the 10%, which I always mention in my program, that we voluntarily do three things. Number one, we voluntarily remain or refrain ourselves from awareness. We tend to remain so much in denial that we tend not to learn about cancer. That's number one. We believe that, no, it will not happen to me. And number two is, we ignore the possibility. So number one, we are not educating ourselves. We are scared of educating ourselves. We fear it. Number two, it's ignorance. Ignorance is that we just simply walk away from the total concept of cancer. That, we should be tested, we should remain in touch with our specialists for whatever reason, for all obvious reasons. And third is negligence. Even if we have symptoms, we remain in denial that, no, it is not cancer. If I talk about myself, I was also in denial when I was detected in cancer in 2011, because at that time it was dengue that was going all around. And when I went for my blood test with white blood count to 1,000 or 3,000 and your red blood count to 20, 30,000, we all thought it was dengue. But it was my family who sent me back. And on the second night, I was forced to go back to the hospital when doctor said that, no, there is something wrong. And I was put to HDU. And it is only that after 7 days, I was eventually told. By then, everybody knew about it, that I had leukemia. It was only when I was admitted to Singapore in Glen Eagles Hospital, when I came to know that, no, I already had leukemia. So, it's bound to happen. It's bound to happen because we live in that world. We have created a world where it is bound to happen because the world is, our world has become inorganic. We don't take for snacks. We don't take those snacks that we are habitual to have. Even if you go back 20 years, we don't take those inorganic snacks, organic snacks anymore. Even if it is snacks, we have to take something which is inorganic. that is one. Number two is our lifestyle has changed completely. We are so busy that we believe that we don't have time and go to see a consultant. We don't even have time to get our blood FBC, a simple FBC or a simple CBC done in 3 months' time, once in 3 months' time, just to check our system. We don't even have the time to do that because we always feel that we are so much overworked that if we are diagnosed with something, what's going to happen to my work? And number two is the food habit, the way we eat, the kind of the tendency of our the hourly food intake, and number three is the diet, and the intake itself has changed. So coming back to the urgency is that we cannot remain unaware. We have to learn, we have to read, and we have to hear about all the possible cancer, because one thing we must believe, that cancer is treatable now. Very much treatable now. The people that we deal with, they are not of those 10% who are affluent. These are part of the 90% who come from all the non-urban rural areas. And whoever has come at the first stage or the second stage, or if you collectively see the number of patients that we have treated or we have supported, and number of them who have survived, about 10 to 12%, and these 10 to 12% are all were detected at the very initial stage, either the first stage or the second stage. And finally, before I go to I go back to, I'm sure I have another point to discuss, which is how we can aware ourselves. That we can come to that later part.
Yes.
Just let me start by saying this, that the cancer this cancer which is digestive, to do with digestive system, since they are kind of not so much spoken about in Bangladesh as much as the breast cancer, lung cancer, oral cancer are talked about. That is why also the number of cases and the number of mortality are kind of, the ratio is very close. So that is what I'm saying, that it's very important that we have to really educate ourselves as well. Thank you very much. That's all I have to say. Thank you.
Wonderful, sir. That's what actually this webinar is for, to create awareness, to aware all the audiences so that they don't face the situation, the condition is already advanced. So, sir, Dr. Robert Lim, as we are talking about the cancer and all that, I'd like to hear from you about the detection and the test options. So for the early cancer detection, we always usually it is possible to do colonoscopy for the colon cancer and can predict. I mean, we can find that we are suffering from cancer or not. But for other cancers like GI cancer or pancreas cancer, how can be detected with the cancer? What are the test options? And we are hearing lots of about genetic testing. So if you kindly brief us about these are the testing options and detection options for our patients.
Certainly, sure, I'll try my best. So I think you've heard as well that for colorectal cancer, one of the good ways to investigate would be things like a colonoscopy. There are some alternatives which have pros and cons. For instance, it has been demonstrated in studies years ago that even just stool testing for the presence of blood and then going on from there, if there's positive, to do more testing like the colonoscopy, etc., can already make an impact for people to actually have a better chance of finding whether they have such a tumor or anything that may lead to that kind of problem as well. However, of course, if someone is able to actually have a colonoscopy performed, I would advocate that, because that's a direct visualization of the insides of the colon, with the ability to actually take a sample. For instance, Professor Mofazzel also mentioned polyps, and we talked about polyps being the precursor to develop into colon cancer. So if you see such thing as well, you have the ability to remove it and examine it, and actually that unto itself is the therapy as well for that situation. If someone's having a colonoscopy, I would advocate getting a gastroscopy to check the stomach at the same time. It's not very difficult. It's not a particularly highly dangerous procedure at all, you know, and it can be easily done. And then that actually, if you've had it done, it covers that person without any other particular risk factors for another 5 to 10 years before they might need another scope. So that's one thing that people can do to help themselves, because very early tumors in the stomach or colon often do not have symptoms at all. And this is one way to actually help detect that kind of possibility, because the chance of curing the person is much higher, obviously, if it's an early stage. Many of the symptoms that Professor Mofazzel mentioned earlier, unfortunately, tend to be associated with late-stage disease, where the chances of curing the person may diminish, especially if it reaches the point of being a stage 4 cancer. The issue of the other tumors, like cancers of the liver, cancers of the pancreas, there's a little more tricky, where cancers of the liver are concerned. If someone has particular risk factors like hepatitis C infection, chronic hepatitis B infection, it shouldn't be a problem in Bangladesh, because, but alcohol consumption obviously is another factor. If such patients have, demonstrated, findings of cirrhosis as well, then these patients are at risk of developing primary liver cancers. And we would usually advocate screening with 6 monthly ultrasounds and blood tests for the AFP and such like, and to act upon such results if they show some change. Pancreas cancer is a difficult one. The pancreas is an organ in the upper abdomen at the back, and often small tumors will not usually cause symptoms at all. The trouble is that for the regular population itself, regular screening has not demonstrated any particular good benefit. If someone has a very strong history of pancreatic cancer and there are particular risks, then we may therefore in that situation have a discussion about a particular screening protocol for such people. But unfortunately, by and large, for pancreatic cancer, there isn't any data to suggest that regular screening will actually detect that. So that's a tricky one. You mentioned genetic testing, and that's an interesting thing, and how to apply that. Now, genetic testing is really just to determine that for a particular patient and his or her family, whether they have a particular syndrome that tells us that that family has this kind of risk, which may therefore in certain instances be passed on to the next generation, and that risk of developing certain types of cancer. So colorectal cancer, like the FAP syndrome we mentioned earlier on, the Lynch syndrome, that's where colon cancers, especially in the 40, 50-year-old age group, or less than 50, there's certain criteria to be met, either colon cancers or colon cancer, plus other types of other cancers like womb cancer, endometrial, even sometimes stomach, urothelial tract cancers and biliary tract cancers. Some of these form a particular group of Lynch syndrome, and this kind of testing that we can perform for them. But the testing is therefore only just to determine whether the family has a particular risk of that. It doesn't help with the screening. So if we do diagnose a person with Lynch syndrome, and then we may then recommend that for him or the family members to have particular type of screening for the particular cancers that we're concerned about. Yeah? Exactly.
Exactly, sir. Because we know whenever any patient visits in Singapore, they feel that, oh, we need to do genetic testing. But genetic testing result comes quite later on. I mean, it takes time to get the result.
May I just add, perhaps, genetic testing, there are probably two aspects to this. One is what I just mentioned, genetic testing where you have a suspicion that there is a family cancer syndrome, right? of being,
Yes.
that's one thing. But sometimes I think it may also be that genetic testing is when what Professor Mofazzel referred to, when we're testing for certain genes in the cancer cells to help us determine the issue of what type of treatments may be suitable to apply or not apply. That I wonder whether that's also part of the other issue, because now we are much more informed for certain types of cancer problems about such testing to tell what kind of drugs we could apply or not apply. And that includes the possibilities of these newer treatments like immunotherapy as well. We do certain types of testing to determine those sort of possibilities or not. Okay.
Exactly. Sir, Dr. Mofazzel, sir, do you want to add something with Dr. Lim?
No, he just narrated everything related to the genetic counseling, genetic testing, and actually this is the main bottom line message is, if you want to detect the cancer early, then you have to start screening. Screening means testing an individual who is free of cancer, who is otherwise healthy. That can do certain things. That can detect the cancer early, that in a stage when it is curable. That can also detect your polyp, which can be removed, and if biopsy shows adenomatous polyps or dysplastic polyps, those are high-risk patients, and they should frequently be checked for the recurrence of polyps. And if there is some family history, the screening should start a little early. Normally, we recommend at the age of 40 to 50 years, and it should continue up to 75 years, or if the person has other comorbid illnesses which will not allow him to survive for more than 10 years, then we can stop at the age of 75 years, right? And for the familial one, I said it should be started early. And if there is polyps and there are multiple polyps, then the possibility of cancer is high. Then they can even undergo total colectomy. That is a prophylactic measure, preventive measure to get rid of the risk of colon cancer.
Exactly, sir. Sir, few of our patients wants to know that whenever any patient is suffering from liver cancer, he is suggested to do scope of his colon as well. So why liver metastasis disease in colorectal cancer is just so important? Because as per our concern that the colon cancer is higher in risk to develop liver cancer, and as 25% of patients at the time of colorectal cancer can diagnose with can develop liver metastasis. So is it actually the situation? And how you treat the patient with a liver metastasis?
Right. There are two things: liver cancer and colon cancer spreading to the livers. Liver cancer is a separate entity. This is caused by alcohol, hepatitis B, C, etc., as Prof. Lim has nicely narrated earlier. But when the colon cancer spreads to the liver, colon has a blood supply which drains through the liver, so it has a propensity to get deposited in the liver. So when it is in the liver, it is stage 4 and it's not curable unless that is a solitary met. That means a single lesion in the liver along with colon tumor. In that case, you can remove the liver metastasis by surgery also, followed by chemotherapy. But if there are multiple lesions in the liver, then it is not curable, and it is only amenable to the chemotherapy and immunotherapy, which is currently being practiced. Those patients initially may not undergo surgery, but with treatment, if there is resolution of the liver lesions, then there may be consideration for the surgery of the primary lesion. If there are certain local symptoms, then also there is possibility of surgery, such as bleeding or obstructive symptoms. Then the questions of surgery comes. So treatment of the stage 4 or when the colon cancer spreads to the liver lies mostly on the chemotherapy and immunotherapy, right?
Yes.
May I just add as well? I think that it's very important to actually distinguish the fact that when colon cancer or any other cancer spreads to the liver, the cancer does not get renamed into liver cancer. So liver cancer is dedicated to primary liver cancer, originates in the liver. So this is actually not an uncommon misconception that many people have, to think that, oh, my uncle had colon cancer and liver cancer and lung cancer. You know, it's not really often that, very seldom is that case. Now, because of the way the blood leaves the intestines, the blood that leaves the intestine all goes to the liver first. Hence, actually, the liver is the most common site of metastases from colorectal cancer. So up to 50% or perhaps around there of metastases from colorectal cancer would present in the liver. Now that can therefore also present a unique opportunity, as Dr. Mofazzel referred to, because if the liver, if the liver is the only organ which has metastases, and if there are few in the liver, then sometimes we look at the option of surgery to remove part of the liver with that, because it could be that that's the only site of disease. So this is something that which has been studied and practiced for many years now, and shown that we can actually make a big difference for patients to give them much better control disease, or even possibly a cure in that way. So in fact, sometimes even if patients have bigger tumors in the liver where initially you think, you know, it's not quite feasible to think of surgery, but if they respond very well to chemotherapy, then we sometimes have the option of converting an unresectable situation to a resectable situation. And that has been shown to confer an improved survival benefit for patients. Yeah. So these are some important concepts to consider as well. Of course, if there are multiple lesions, as Dr. Mofazzel has referred to, or cancer beyond the liver as well, in the lungs or in the abdomen cavity as well, then surgery has no real role for that situation. There's primarily the use of chemotherapy drugs and such like, you know, and to control the cancer. We can benefit the patient that way, but it's a different situation. Thank you.
Yes, sir. Definitely. So since you were bringing the question about that, the treatment options, immunotherapy, targeted therapy, and lots of terms are coming when a patient suffers from cancer. So if you kindly briefly inform us about these are the advanced treatment options for the cancer patients.
Sure, certainly.
Dr. Wasim, and then I'll hear from Dr. Mofazzel, sir.
Okay, certainly. So, you know, many years ago, and even till now, of course, chemotherapy, of how we think about chemotherapy, cells which affect cells dividing, are one of the important drugs, treatments to consider for cancer problems, including obviously colorectal cancer. Now, in addition to that, we now also have certain targeted agents. For colorectal cancer, the two main targeted agents that we think of are usually either targeting the blood vessels or targeting a growth receptor on the cells itself. For the targeting of the blood vessels, that essentially helps the chemotherapy penetrate the organ and the cancer specimen more, so that the effect of the chemotherapy can be enhanced and the control is much better for the longer term. And that is beneficial for many patients. Now, for the cancer, the targeted treatment that directly inhibits or blocks the cell growth signal, there are important genetic tests that we were talking about earlier on, BRAF, KRAS, NRAS, because mutations in those genes tell us that such treatments will not work. There's resistance to such treatments. So it's important to do that kind of testing to know whether we should be applying it to such patients. And in fact, more recently, over the past few years as well, more data has even informed us that the site of the origin of the colon cancer on the left side or the right side of the body also has importance in terms of how we as oncologists view it and make recommendations as such as well. Now, the third arm of the treatment that we are now thinking of sometimes is immunotherapy. So this is a very exciting development over the past 5-6 years or so, where we now have drugs which basically take the brakes off the immune system. So you start to rev up to get the immune system work harder. But that's not just simple. I mean, it may sound simple, but it's not as easy as that, because not all cancer problems just automatically respond to immunotherapy. So for colorectal cancer, by and large, it is a small subset of patients which have what we call microsatellite instability high, MSI high cancers, which have a higher chance of responding to that. This group, unfortunately, is only about probably less than 5% of stage 4 patients, which is the group where we would use it in. But most recently in June at the American meeting, there was a very important study which was presented and discussed, where patients with MSI high colorectal cancer in stage 4 were either given conventional chemotherapy, good conventional chemotherapy, 2 or 3 drugs, versus immunotherapy, and immunotherapy came up tops. It had a better chance of controlling the disease for longer, and that essentially for this particular special group of patients is one thing that we would now want to look for and recommend should that be possible. Now, just as one...
Is it the side effect of immunotherapy is less than the chemotherapy?
It is. By and large, it is less. There are still side effects. There are unique side effects special to immunotherapy, and some of them can be also pretty serious sometimes, but by and large, as a whole, it's less. But I think here, what's very important is patient selection. I think we shouldn't just be taking any patient for colon cancer stage 4 and giving them immunotherapy, because we have enough information to tell us that unless that patient has MSI high tumor cancer of the colorectum, that they will otherwise not respond well at all to the immunotherapy. So it's a very small select group. Last but not least, even some of the breast cancer treatments nowadays are also making inroads for colorectal cancer. There's a receptor called HER2, is also another growth factor receptor, and in breast cancer, about 20 to 25% of breast cancers have HER2 positivity, and there are drugs like Herceptin, trastuzumab, and others which work on that. In colorectal cancer, in a small group, again, it's only about less than 5%, unfortunately, but HER2 positive colorectal cancers can benefit from such similar breast cancer directed type therapy as well. So this is something, things are evolving, changing all the time with more options available to some patients. But importantly, it will be to make sure the tests done are the right tests and we find that they are suitable for these treatments.
Exactly, sir. Thank you so much, because cancer detection, proper treatment is absolutely important to support a cancer patient. It's a combination of support from the oncologist, family, and the patient herself or himself. So, Dr. Mofazzel, sir, if you want to add something with Dr. Robert Lim with this note.
No, he vividly described the recent treatments, particularly about the immunotherapy. We try to detect the certain altered cellular mechanism and the findings which enable us to use those molecules such as PDL1. Then we can add the new drugs, immunotherapy drugs such as nivolumab, pembrolizumab, and the other molecular testing he already mentioned, for which we, if they are wild type, then we can use cetuximab or panitumumab. But these are already in practice, and new things are coming up, like HER2 positive cases may even be benefited by a drug which is being used in the breast cancer treatment widely, right? So these are most important thing for colorectal cancer, that we need to know how to be safe from the colorectal cancer. That means how can we protect ourselves from colorectal cancer? This is more important for the general public than a theoretical discussion or treatment elaboration, right? Sorry. I think the main important things are, one has to be physically active, right? So physical activity is a protecting factor. Diet high fiber diet rich in fruits, and some supplements like folic acid, folates. Then one important thing, those who take ecosprin, I mean aspirin, they have a low chance of developing colon cancer. This is proven. So this is very important. And one has to take more fish rather than this red meat and others. Other like the vitamin D, magnesium, garlic, these are said to be protective. So we should all try to consume those more and more. And please give up tobacco, alcohol, and try to be obese, not to be obese with the fast foods. Nowadays, it has become a trend of the young generation to take plenty of fast food and become obese. You see with the affluence and development in our country also, we get more and more people in the obesity range of their BMI. So these are higher risk people, and they should be careful about this. And finally, the most important is if you are in the age group of 40 to 50 years, you must go for screening. Screening by either of these two. It is better that you practice both colonoscopy and fecal occult blood test. These two are good enough. But there are other methods, but these are the simplest and easiest, and it is available almost everywhere. So these are very important issues one has to remember and practice. Not only remember, one has to practice. That's the message.
Thank you so much, sir. So, Albab Bhai, that the concern is coming from both doctors about the awareness and how we can aware between the patients for the early detection. So, if you want to add something with this, all the information.
This is something that Bangladesh Cancer Trust have been doing. We have been visiting universities, we have been visiting schools where we're taking some time and making the students aware on two different capacity. School students are, of course, the who are remain very close to their parents, and they're the ones who can always convey the message to the parents. Talking about the university students, we are actually they are the immediate future leaders. So when they go out of the university, and when they go to the corporates, that is where they are supposed to make the difference. And when we are now reaching out to the corporates, which we have been doing until the pandemic, we have emphasized on, again, a few things. Number one is any kind of well-being, as far as health is concerned, creating awareness is the best possible CSR that an organization can do. Is making the workforce, making the employees aware of the fact that they need to be healthy, and not only by intake, but at the same time by knowing about certain illnesses, and cancer is one of them. That's number one. Number two is it's mandatory for, all the organizations can make it mandatory to which I know is an uphill task, but then again it can make them mandatory by making sure that every employee every 3 months has to submit a blood report saying that, okay, fine, I've done a CBC, I've done an FBC, and this is it. And number three is for people like us who are voluntarily doing this service, and we don't take any money for this, is if we are given the opportunity, we have reached out to many corporates. Through you, I can reach out to many corporates, of course, with your contacts, where we'll go and we can always do sessions where we can pass on the message about cancer. So these are the three things. And it is, finally, let me say this, that knowing about cancer, it should be, for me, where I'm coming from the space that I'm coming from, knowing about cancer should be a part of and parcel of your literature. If you really want to look forward to another decade down the line, a healthy decade down the line. Thank you very much.
Exactly. Thank you so much. Actually, that's the responsibility, social responsibility for us. And being a part of BANCAT, we are trying to work for with this social causes. We're trying to aware our patients before visiting our doctors for the advanced treatment. So yes, this is the right time to think about our health. And since it's a pandemic, already we know that health is the most valuable asset for us. So we need to be concerned about our health. So Dr. Lim, just
to add,
yes,
you
please,
see,
please.
The word of mouth matters.
Yes.
Physical presence and the word of mouth matters. So our physical presence and our word of mouth can make that difference. Thank you.
Inshallah. So Dr. Lim and Dr. Mofazzel said this is the last question from our side, since the topic is on the COVID situation, how we manage our cancer. So during this COVID situation, what should be your advices for the cancer survivors? Then we have few of the questions from our audiences. I will ask selectively to you. So Dr. Lim, please.
So I think the COVID situation is really changed how we have to and need to look at how we take care of our patients. Certainly, I think at this point of time where things may not be fully under control yet, there's still a lot of concern about transmission all around, where visits and consultations are not absolutely necessary. It's not deemed to be, potentially so crucial. We should try to delay those or try to do it under like this sort of setting, telemedicine of some sort, if possible, to try to help with that, decrease the chance of exposure. But certainly, because cancer has a potential to become such a even more of a life-threatening situation. I mean, the diagnosis itself is already, one of those issues. So not infrequently, we have to say we need to consider treatment. Now, here comes then the issue, of course, how crucial is the treatment as well. And then, as Dr. Mofazzel, I'm sure he has faced, especially in your situation with ongoing problems and, over there as well that we have, the discussion of like, is it worth doing the treatment? How much degree of benefit is there versus the chance of risk, as well, illness? Because what we do know is that patients on treatment have a higher chance of, of COVID illness and sometimes possibly more severe COVID illness problems as well, complications as well. Then you also have the group where it's imperative that they have treatment, be it surgery, right? You have a colon cancer diagnosed and you find that it's localized, there's no spread. My goodness, if we don't operate, that will become a problem and become metastatic. How to take care of that situation and keep everyone safe in that situation. And then following that as well, let's say that patient has stage 3 colon cancer, and we advise, as often we do, to give chemotherapy. What are the possibilities and the styles, regimens of chemotherapy where we might be able to do it such that the visits to hospital are not as frequent as well. So these are some of the issues and discussions that need to take place. It's a two-way discussion to ensure that everyone is on the same page and you have all the information there to make the best judgment for this situation. Because it's truly a difficult situation. There are issues to do with the cancer concerns and also concerns about COVID and its sequelae as well. Dr. Mofazzel.
Yes, I fully agree with you. And we are actually following certain guidelines from the different bodies that we follow, ESMO, ASCO, NCCN. But taking consideration into the special situation of COVID, we are trying to do certain things. We are, first of all, trying to create awareness among our patients that you must take extra precautions other than the one which is being taken by other people, normal persons. Because you are an immunocompromised, and if you do develop COVID, your chance of not recovering is higher than the normal average person. So you should take extra precaution. Right, putting on mask, washing hands, and protecting yourself. These are all there. These are the normal practice. Everybody is doing that. But about the treatment, we try to make the hospital visits as less frequently as possible. So if someone is getting a weekly schedule of chemotherapy, we try to delay it, maybe 3-weekly schedule, maybe a reduced dose to minimize myelosuppression, and using the growth factors so that after chemotherapy, the myelosuppression, chance of myelosuppression becomes minimized. Then I can quote example. A newly diagnosed young lady with breast cancer came to me. I thought the surgeon will love to go for surgery. It was a very small tumor, 2.5 centimeter. I referred the patient to a surgeon. He said, no, I'm not doing the surgery right now. Go to the oncologist and get the chemo passed. Well, I started chemo, and after 4 cycles, after completion of the neoadjuvant chemo, I found that the tumor has completely disappeared. That means she has gone into complete CR, complete response. But what to do now? She has to wait for the surgery. Then to complete her treatment, she has to go for radiotherapy. Every subspecialty is modifying their treatment schedules. The radiotherapy people are doing hypofractionation. They are making less frequent visit to the hospital by the patients. And we are also modifying our chemotherapy schedules. And those who are on routine visit to us, we are delaying them. We are discouraging them to come to hospital, because hospital is not a good place at all. And even with the doctors are not good people to come in contact with the cancer patients who are otherwise who have completed their treatment, but they are on routine checkup. We are discouraging them to come if there is no serious problem. The bottom line message is, try to take care. We are trying to taking care of our patients so that they do not develop severe myelosuppression. They have to come less frequently to hospital. We are modifying our chemotherapy schedule, less toxic chemotherapy, and sometimes we are switching over to oral chemotherapy rather than the injectable ones. These are actually the practical aspects we are considering.
Your discussion, Exactly, sir. So relating to your discussion, there is a question from a patient audience, Mr. Imtiaz, that if the existing patient delays their chemotherapy or treatment for cancer, is that okay for now? How long the patient can wait for the chemo or radiation?
No, if the patient is already on chemotherapy, then he or she should continue the chemotherapy, and the oncologist concerned will decide the modification of his or her treatment schedule. Without knowing the details of the schedule, I cannot make a comment completely, right?
Yes. Okay. So another question. I'm just taking some 2 or 3 questions, and will finish this session here. We know lots of questions will come to the audience mind, but this session is not enough for the discussion. It's a vast field to discuss. But still, I'm taking up few questions from the patients. Mr. Ronnie asked that are gastrointestinal and colorectal cancers truly
Oh, yes, we mentioned this earlier. I think that as long as you can detect it and treat it at an early stage, so that's the key thing. And that's why, at the very beginning as well, when we talked about polyps, and there was some mention of concern about polyps, and I actually they removed. That's good, because they're actually not even a cancer at that point of time. Decreases the odds that that person will symptoms, unfortunately, that's a little more worrisome. Sometimes we can still find that it's at an early stage, but I think it's important to have these discussions with your doctor to talk about going for screening, meaning that you are not symptomatic, but you're of age or certain risk profile in your family, perhaps, to say that it is time to get some screening tests done, like colonoscopy, plus or minus a gastroscopy to check the stomach as well. Thank you.
Thank you, sir. So last advices from all of you for our patients during this time, and especially for not to get this deadly diseases. So I'll hear from Dr. Mofazzel sir, then Dr. Robert Lim, and lastly Nazmus sir.
Well, the message from my side is to remain cancer-free. You have to abide by certain things, very common things. Take good food I mean foods containing plenty of fibers, plenty of vitamins. You should have some vegetables and fruits in your regular menu. Take physical exercise. Physical exercise is very important. Then don't get obese. Then certain things are there which are usable and which can be used to prevent certain cancers. We are talking today about colon cancer. We have said about ecosprin. If someone is taking ecosprin for some other reason, such as he had a heart attack or some stroke, for that he is taking ecosprin, this is a byproduct benefit of that individual. Then if you have attained that age, then you go for screening so that we can detect the cancer early. And during this COVID situation, we should be very careful. We should not forget that it can be, you can keep yourself safe from COVID by just avoiding the instructions being given from different bodies. So you should all try to follow those up, and finally remain COVID-free and cancer-free. This is my wish to all of you.
Thank you. Thank you so much, sir. Thank you for your time. Sir, Dr. Robert Lim, please.
Yes, thank you. The same thing. Dr. Mofazzel has mentioned all the key things there. I think in maybe just a perspective is to be aware of your own health, be aware of your own risk. For instance, if you know there's a strong family history of cancer, seek help to understand that better, to know whether you should be doing certain tests at an earlier stage and things like that, or special tests, or getting advice. Knowing your risks and doing away with risks. Smoking, that's one thing which we always say as well. Obesity, that was also mentioned, is now recognized to be a new risk factor that was not noted previously, and that's something. So exercise as well also helps that. So these sort of things, and knowing yourself, knowing that you should get these tests done, screening tests to look for things at an early stage as well. But of course, if something actually were to happen, then to be aware that you need to seek attention soon, quickly, to get it sorted out, diagnosed, so that you can have it taken care of as best as possible, as quickly as possible, to get the best outcomes. Yeah. Where the COVID situation, of course, yes. I mean, for sure, all the things that are being discussed and suggested, recommended, masks, safe distancing, hand washing, awareness and avoidance of very crowded places as much as possible, I think is key. So again, I also wish all of you well. I thank you all for the chance to participate in this. I hope it's been a helpful discussion. It's been also rewarding for me to see my good friends again as well. Yes, so thank you very much.
Thank you so much. So Mr. Nazmus, sir, please.
Health check, regular health check. I mean, minimum health check. Just a simple blood screening, that's all.
Yes, exactly.
Fair enough. I mean, you're not going for cancer check. You're not going for cancer check. You're not bound to have cancer. It's just that keeping healthy, knowing where your health stands at this point of time. That's it.
Thank you so much. Thank you so much, everyone, for your time. And I think this discussion will be a very helpful for our audiences, especially being aware of the situation, being aware of their health, and definitely will come with a different topic with different doctors from the international hospitals, from the Bangladesh platform. So see you then, and stay safe, and thank you. Goodbye, everyone. Thank you so much.
Thank you.
Goodbye.
Bye-bye. Thank you.
Bye.
Thank you. Yeah.
Yeah,